My name is David McDaid. I work at the London School of Economics. I'm a health economist. I specialise in the area of mental health. And what I want to say today is that we need to focus much more on really identifying all the hidden costs of living with schizophrenia. So that's really about the costs of poor employment, the costs of poor physical health, the costs of lost educational opportunities, and really to argue that we need more on this, and we also need to collect more of this data over a long time period so we can have good, strong arguments that we can make to governments and other policymakers. Merci Marion. Malheureusement, je dois parler en anglais. Mon français c'est très pauvre, c'est très mauvais. Je m'excuse. I'm so sorry, my French is terrible. I will try and talk in English, and my English I will have to try and make good as well. So, as Marion has just said, there's a real opportunity in the work that's happening here in France through the expert centres, through all the data that's been collected on specialist mental health services, to really say a lot about the economic impacts of schizophrenia and also other disorders as well, bipolar and depression and other things that can potentially be looked at. Because the economic impacts, sometimes perhaps you think money and cost, they're not so important. You're interested in helping people, you want them to have good quality lives. But there are many people who are not interested in mental health. There are many people who are much more concerned with budgets and money and costs. And what I want to argue is that you can make economic arguments to help make the case for more investment in mental health, both in research and in delivering services. So it's very important that we count all of the costs, all of the impacts of poor mental health and indeed of positive mental health. So are we counting all the costs, and are we making enough use of this information? And the information I will present is not really about France, but it is all relevant to France. And I hope it makes you think about the ways in which the data, the information that is now being collected can be used to strengthen the arguments for mental health here in France. And I should say that, as Marion says, most of my work is around the economics of mental health, and I've been looking a lot at trying to make these arguments to ministries of health. And in England, actually, we've had some success. We have relatively good levels of spending on mental health services, and even in the last few weeks, at a time near our election, both the government and the main opposition parties have all committed themselves to spending more money on mental health. So, and a lot of that is because of both arguments that there are effective interventions, effective approaches, but also that economically it pays to invest in mental health. So I want to give some examples, and I know for those of you at the very back of the room, it may be difficult to read, but I will leave the presentation afterwards, and I'm happy for, it will be distributed, it will be available, so you can read it if you can't see now. An overview on some of the costs of schizophrenia and psychoses more generally, but I really want to focus on some of the opportunities to strengthen what we know, and opportunities I think you can build on here in France, and then to look at how the economic case can be strengthened to support recovery and from psychosis and schizophrenia. And the positive thing to say, first of all, is actually we know quite a lot about costs, but I have to say not so much in France. As you heard, I was having discussions this morning with Charles and Amélie Prigent and others, Marion and others, about the costs of schizophrenia in France, and some very exciting work looking at the costings here. But there aren't many studies in France. It's actually surprising, in one of the most respected and great countries, there's not so much in the English language on the economics of schizophrenia. But we do know from other countries that there is a lot of information on cost. We know across Europe as a whole that psychiatric disorders are costing every year around 800,000 million euros. So it's a lot of money. I think that's 800 milliard, I think you say in French. Substantial costs, and about more than 10% of that is specifically on psychotic disorders. So even though psychotic disorders are relatively rare compared to depression and anxiety, those kinds of things, they have enormous impacts, not just on the health system, but actually outside of the healthcare system. It's probably difficult for you to see, but this bit here, there's about 30 billion euros in costs of psychosis to the healthcare system across Europe, but more than double that, over 60 billion euros in costs because people don't work, because people have died prematurely from physical health problems. It's because they are excluded and marginalised from society. So there are big costs outside of the healthcare system as well as within the healthcare system. This is data from England, and again, what it's showing in England alone, it's costing the country around 12 milliard in terms of pounds. And the public sector, the public purse, more than 7 billion pounds, 7 milliards. And again, the thing to notice from this, if you can read this, yes, there are costs to the healthcare system, but it's only about so much. Only about 30%, 30 to 40% are costs to healthcare systems. The rest are costs in terms of unemployment, the need for families to provide support. Sometimes we forget about families. Families give up time from work. They worry all day or all night because somebody is not sleeping. They're walking around, pacing around in the house. They lose out on their career opportunities. So there are costs to families. There is costs to the state because the government pays out unemployment benefits or disability benefits. And maybe some of that could be avoided. People could be helped to recover more, to go back to work. They lose out from education as well. You think about psychosis. So many cases of psychosis, at least for men, happen between the ages of 14 and 25. The time when we are in the middle of our education, our learning. People drop out of school. They drop out of university. They may not get the qualifications that everyone else gets. That's a huge cost, both to individuals personally and to society. And it's not just in Europe. We can see, and you can't see these numbers here now, it doesn't really matter so much, but all around the world you can look at the costs in Japan, for instance, of schizophrenia, and you get the same conclusions. Around 2/3 of the costs are outside of the healthcare system in terms of lost unemployment and premature death related to schizophrenia. You can even see this in low-income countries or middle-income countries. In Thailand, again, in Thailand, the numbers are not so important, but it's the way in which the costs are allocated. Most of the costs, again, fall outside of the healthcare systems. They fall onto families. There's less support there. They fall onto families, but still 20% in the healthcare system in Thailand. But I could spend all day, I could spend 2 hours talking about costing studies. And I know that you're mainly psychiatrists in this room rather than economists. So I have to issue one word of caution. And this is why the work in France that's happening now here is very important, is to really do these things in a good way, to be very methodical and transparent in the way in which data is collected. Because it's possible for studies on the costs of schizophrenia to come to completely different conclusions, not because the data is different, but because it's been interpreted in a different way. And just a couple of examples of that. This is maybe a little difficult to see, but it's a recent study from Germany. This is a study from Germany using patient record data on the economic costs of schizophrenia in 2013, I think it was. And they show two perspectives in terms of the cost. How much it costs the health system, the payer, whether it's insurance systems in Germany or the government, how much it's costing them, and how much it's costing all of us in society, from people being out of work or people dying early. That has costs beyond the health system. And what you'll see, which is very different about this slide compared to what I've just been saying, is that they identify lots of medical costs. They say up to maybe 15 or 20,000 euros in medical costs. But they say they talk about indirect costs. That means the productivity losses, the costs beyond the health system. They are almost non-existent in the German study. Why is this, you might say? I've just been saying there are lots of costs about people being out of work. Well, in this particular German study, they have assumed that once you've lost your job, someone else will take your job. So that there's no cost to the economy of losing your job. You know? We don't need to argue about the rights and wrongs of that, but you have to be very careful on the way in which these studies are interpreted. So I think this undervalues the impacts of poor mental health, personally. But at least they say what they do, so it's possible to know why the study comes to a different conclusion. So that's important. Another example comes from Spain. This is quite an old study now, but it looked at the costs of schizophrenia in Spain. And again, what you'll see here is that around 40% of the costs are to do with the healthcare system, hospitals, well actually 50% with drugs and outpatient visits. Again, there are no productivity losses, no impacts on employment. But they do have lots of impacts on families. They worked out almost half the costs of managing schizophrenia in Spain were due to families having to give up their time to look after a loved one. Okay? But the employment costs are missing, and they're missing because in Spain, at the time of this study, there was no accurate information on people's work histories or whether they were unemployed or registered with a long-term disability, so they couldn't do the analysis. So you have to be very, very careful about what is actually costed. Okay? But the important thing from I guess, an advocacy perspective, or to really emphasise the work you're doing, is to show how profound these impacts are, how much difference it makes to people's lives to be living with mental health problems. And it really is to emphasise to those who are not experts in mental health or who have little interest in mental health, that these impacts affect them as well, because they affect the whole of society in very different ways. And I really want to highlight one issue in particular in this lecture, and it's one which I find, I just find it extraordinary actually. In most of the economic analyses that have been published, very little is said about multi-morbidity, about people living with psychosis and schizophrenia who are living with diabetes or cardiovascular disease or respiratory diseases or all sorts of problems, because they are the biggest killers of people with long-term chronic mental health problems. And again, how can we really say that we're looking at the total impacts, the total consequences of living with a mental health problem if we don't also look at the higher risks to physical health? And also, if you are the Minister of Health, or if you are responsible for how money is spent in the health system, and you're not interested in mental health, but someone says to you, if you actually invest more thinking about the physical health needs of people with mental health problems, that could help reduce or avoid some costs to the physical health system, then maybe that's an argument that they will listen to. So it's really important to try and think more about recording information on the physical health consequences of living with a mental health problem. And there really is not very much published out there. Myself and a colleague from the LSE, we published, actually this is in a volume from Professor Norman Sartorius, who's a psychiatrist, and Richard Holt, who's a diabetician, recently, looking at the costs of comorbidity. And what we found, well, two things we found. We didn't find very much. That's the first thing to say. There are not so many analyses that look at the costs of having comorbidity. But what we find, for instance, is that if you have schizophrenia and you have obesity as an issue, the costs of treating the obesity are 30% higher than they are in the general population. This is not about the cost of the mental disorder, it's just the cost of the physical disorder. The costs of dealing with diabetes in another study were almost double the costs they normally are for treating somebody with diabetes. You can see similar results for dyslipidemia, hypertension and heart disease. And there are some other studies as well, not shown on that slide, but they're rather limited, and most of this data comes from the United States. There's a real opportunity to say a lot more about the impacts on physical health in France and in Europe more generally. Why is this important? Well, let's forget science for a minute. Let's just be human beings and look at this slide. I find this slide one of the most extraordinary things in mental health, to be honest. And it shows three countries, Denmark, Finland and Sweden. Three countries with fantastic healthcare systems, good quality of life, good social support safety nets. And yet, in all three of these countries, if you live with schizophrenia, you have a reduction in your life expectancy of between 10 and 17 years in some of the most egalitarian societies in the world. If you're living even with affective disorders, a depressive disorder, you can still lose 10 years of your life expectancy compared to the general population. This is not new data. Everyone in this room, I'm sure, probably knows this, and it's been around for a long time. If this wasn't about mental disorders, if this was about some physical disorder, and we were saying people were living sometimes 20 years less than the general population, there would be a lot of people saying this is unacceptable. But it doesn't happen so much in mental health. And I don't understand why, to be honest. But all I can do from an economic point of view is try and highlight the additional economic costs of people dying early from physical health problems that could have been avoided, and people living with additional physical health problems that could have been avoided. So, you know, I'm sure, I don't know the French situation, but I would imagine if you did this analysis in France, you'd find similar kinds of results. Big differences in life expectancy. We do in London. Again, this data is difficult to read. This is data from people in contact with specialist mental health care systems in London, so severe disorders, where again, life expectancy for people with schizophrenia, for men, is 14 years less than that seen in the general population, and for women it's 10 years difference. And you can see differences as well for the affective disorders and for substance abuse and bipolar disorder. So big differences in life expectancy. And these are for people who are in contact. This is registry data. These are people who are in contact with specialist services. So there are enormous economic costs of mortality, of premature mortality, and really I would argue very strongly that one of the missing things, something we're not counting the costs of enough, is this cost of premature mortality and morbidity, living with these extra chronic physical health problems. And it also, just very quickly to say, it works the other way as well. I know today we're talking about people with schizophrenia, but there's also evidence, for instance, that some people living with a chronic physical health problem have increased risks of having certainly depression and affective disorders. And if you manage, again, the depression and affective disorders better, you can manage the physical health problems better. There is this overlap. We don't live... I know Descartes separated mind from body many hundreds of years ago, but there's an overlap. There's an overlap. And we estimated in a study in London, well, for England, that for about €1 or £1 in every €8 it costs to manage long-term physical health problems is actually due to mental health needs. There's a big overlap. big costs. We also know from studies that if you are living with a long-term mental health problem, it increases the costs of managing the physical health problems. I've said that before, but it's worth reinforcing again. And the more physical health problems you have, the greater, again, the costs of managing them. So one point I'm really trying to argue is that there's potentially a strong economic case to be made for having a mental health system that puts even more emphasis on managing physical health as well as mental health. And I think probably in France, as in England, there may be challenges in the way the systems are organised. Sometimes there's a separation between the mental health system and the physical health system. And there needs to be more opportunities for collaboration and coordination. The role of liaison psychiatry is very important, but also the role of primary care in protecting the physical health of people with long-term mental health problems. Just one example again of why this is important. This is data from Spain, and it's showing hospital admissions in people with schizophrenia by different age groups. And what you see here is that, yes, there are, in younger people, the greatest number of admissions are related to schizophrenia happen in the first years of life, between 15 and 35. But over time, there are more and more admissions for physical health problems. Now, I would argue that probably some of these physical health problems and the admissions are avoidable. And yet we don't think about that so much when we're costing the impacts of schizophrenia and indeed other mental disorders. So the question is, how much of this cost is not included when we talk about the impacts of mental illness, and how much of it is avoidable? If some of it is avoidable as well, it strengthens the argument even more for investing in better ways of treating schizophrenia. Just to build on this further, we did some work at the LSE just trying to model some of the potential additional economic impacts of living with poor physical health if you have poor mental health. And what we did was we identified the excess risk in people with schizophrenia, diabetes and depression. Bipolar and depression in terms of the risk of diabetes and the risk of heart disease. And I won't go through the whole analysis, but across the whole of Europe, there are substantial costs, 7,000 million euros in terms of avoidable diabetes treatment costs, type 2 diabetes, and avoidable cardiovascular disease. Now the question is, of course you can't avoid all of that. I'm not foolish, you can't avoid all of these extra costs. And let's move forward a slide a second there. But even if you could just avoid 1%, 1% of if you could reduce the additional risk of having diabetes or cardiovascular disease by just 1% across Europe, you could avoid getting on for 500 million euros every year through a very tiny reduction in the incidence of new cases of cardiovascular disease and type 2 diabetes. And that's a very, very, very modest goal, a 1% reduction. Hopefully we could achieve a lot more than that. So there are big costs, both for schizophrenia. You can see here the cost of schizophrenia in total, more than 116 million euros in extra cost just managing these two physical health problems, so that they are substantive. And they also have impacts in terms of productivity losses as well. There's additional time out of work because you're managing, because of the diabetes that you now have because of your schizophrenia. Okay? And the other thing I've not mentioned on the slide, but it's a really important point, the risk, take diabetes as an example, the risk of having a complication such as an amputation, losing your foot to diabetes, the risk is higher in people whose mental health is poor because they don't manage the diabetes care as well as the general diabetic population do. So better physical health, better physical health can be one of the outcomes of well-managed mental health problems. But it means really, first of all, arguing and highlighting the impact on physical health of living with poor mental health, and they're recognising that the mental health system has an important role to play in dealing with this issue, both through I imagine here, when people come into the system here, you do all the blood checks and lipid screenings and all those things. But maybe that could be done sooner, or maybe the primary care system has a role to play in managing people's blood sugar levels in the long term. So there's lots and lots of things to think about there. It also raises issues about how we actually think about these issues, how we manage them, how we treat them, and maybe more can be done to think about the economic case for better measures to control diet or to help people manage their diets and exercise and those kinds of things. And we do know, this is a recent study published in the Acta Psychiatrica by Peter Horth and colleagues, there are interventions out there that have been proven to work in helping people to reduce their weight in people with schizophrenia. But, and again, this is one of the gaps, we try to find any evidence on the cost effectiveness of measures to promote the physical health of people with mental health problems. And we found, quite frankly, almost nothing, really. The only things that we were finding in terms of schizophrenia, really, were about smoking cessation, about hard drug abuse, about sexually transmitted diseases, about tuberculosis. And a lot of this was studies published 20, 30 years ago, you know. And we did find some things around lifestyle and weight management, but they tended to be focused much more on depression and anxiety disorders than they were actually on psychosis, even though we know that there's the risk of metabolic syndrome and weight gain and so forth. So there's a missing case there. But potentially there are economic payoffs to be made. A guy called Nick Verhage, who's Belgian, he did some economic modelling work looking at the cost effectiveness of a health promotion programme targeted at people who were long stay residents of mental health institutions in Belgium. They did a complicated model. There are overlapping risks of having heart disease and diabetes and various cancers and strokes linked to the higher risks associated with poor mental health. You don't need to worry about that, but it's just, that's what they did. And what they came up with, there's lots of numbers on here. You don't need to see them all, but there's a couple of things to say. That they looked at different scenarios, assuming different levels of effectiveness for the different programs and different costs. And there are many scenarios at the very end of this analysis which would be considered in France and in the UK and most of Europe to be highly cost effective. They are going to cost money, but they're going to improve quality of life by such an amount that most healthcare systems would consider these good value for money. So there are lots of opportunities here again to think about physical health issues. And they often say in presentations, put on things that you've done yourself so it gives you more credibility with your audience. So we just produced a book actually with the OECD, which is not just about mental health, but it's about the whole issues around the economics of health promotion and disease prevention. We have a chapter in there on early interventions for people with mental health problems. But the point is, the question to you is, maybe lots of the actions we think about for the general population can be adapted and applied as well to people even with severe mental health problems. So we have the challenge to try and broaden and strengthen economic arguments, and I hope I've convinced you that looking at physical health needs to be part of that argument. But you know, there are some encouraging things as well. Another area where we can try and strengthen the argument is to have longer-term data, longer-term follow-up. And again, this is an opportunity, as I understand, that the data that's now been collected by the expert centres will allow it to happen over time, because you'll be collecting data longitudinally over a period of time. Just an example of how powerful this can be is from something called the OPUS study. I don't know if anyone has ever heard of the OPUS study. No? It's a big trial in Denmark of an early intervention service for people with psychosis. So it's having multidisciplinary teams which try and reduce the duration of untreated psychosis, really try and minimise that. And they followed people over a period of 5 years. The intervention itself lasted for 2 years, but they were followed up over 5 years in total in a randomised control trial across the whole of Denmark. And they included an economic analysis in that. And what they found in terms of the clinical effectiveness was that in the 2 years that people received the OPUS intervention, they had better mental health functioning, really. Global assessment of functioning was better, and also some other measures of functioning were better. They also looked at the economic analysis, and has anyone ever seen something like this before? Does this look completely strange? It probably does. You'll just have to take my word on a couple of things I'm going to say. This often is seen in health economic analyses, this kind of picture. Everything down here in the southeast quarter, everything here means that the new intervention has better outcomes, so it has more global assessment of functioning, better global assessment of functioning, and it's costing less, okay? And what this picture shows, they've taken data from the randomised control trial, many different samples, resampled it over and over again to try and reduce the level of uncertainty about the results. And what they found, in around about 70% of occasions, not only is the intervention likely to save money, it's going to have better functioning. So actually, if I'm a policymaker, I'm actually quite pleased by this, because it's saying we're going to have better outcomes and we're going to save money. We're actually going to avoid some costs. And that can be very powerful from an economic point of view. And maybe there are opportunities to do more of that here in France as well. Strong probability of lower costs and better outcomes. They've done even longer term follow-ups of this study now. There's been a 10-year follow-up, okay? And the 10-year follow-up, again, doesn't show much difference in clinical outcomes beyond the 2-year time period of the intervention. But what it does show, and this is why to think about things in a different way, what it does show is that over 10 years, most people who received the early intervention for psychosis program, they could live independently. They didn't need support with their housing, compared to people who received traditional care in Denmark. So there was a cost saving to the Danish government because of the reduced need to spend money on helping people to live independently. More people were able to return to some form of work. More people were able to go back to live with their families as well. There was much less need for having to invest money in extra housing costs. And I think this is also quite a powerful finding if you're trying to convince governments that it's worth investing in early intervention for people with psychosis. And it's powerful as well because it's 10 years now worth of data. It's not an isolated case. Next to Denmark you have Norway, and in Norway they've done something called TIPS. I forget exactly what TIPS means, but it's an early detection program. It's trying to detect people who may be at risk of psychosis even before the prodromal phase. And they've again followed up on people over 10 years compared to usual care. And there are a couple of points to note here. Recovery rates are higher over the 10-year period in people who had the early intervention program. There are a few of them actually living independently, but more in full-time work, full-time employments, and more having more social contacts, social networks. So most of those outcomes for people receiving the early intervention program are positive compared to traditional, early detection program, are positive compared to traditional management of psychosis in Norway. And again, the point here is not necessarily the numbers, it's the value of having long-term data. And I could talk about other areas which I won't, but there are lots of studies around child mental health where, because there are lots of data sets which show what happens to children who do not have their mental health state improved at the age of 5 or 6 or 7, and it shows you the negative consequences when they're 25. Those kind of studies have been really powerful in convincing policymakers to do something, in some countries at least, about child mental health. Another area I just wanted to make, so I've talked about the importance of physical health. That's a missing area. the importance of having much longer term data, which requires investment in data sets and databases. Another area to look at as well, as part of that data collection, is the issue of employment. Because employment is associated with improvements in health outcomes and reductions in the use of health services in some studies. It's also, again, and apologies for those who think this is a terrible thing to say, but there may be some people in government who are much more interested in reducing unemployment benefit or disability pensions and things like this than they are in the health impacts. So if you can demonstrate that there are interventions that help people return to work or to live financially independently, some people in some governments may be very interested in those arguments. But employment also has a therapeutic effect as well, of course, and it should be part of the recovery for people who choose to do that. There are studies in several places, this is a study from Switzerland, essentially showing that people in competitive employment who were coming into contact with psychiatric clinics, well, put it this way, people who were maintaining competitive employment had less contact with psychiatric clinics than those who were placed into sheltered employments, where you train people and then try and find a job, and those who are not working at all. So employment itself can be beneficial and therapeutic. There are lots of studies done on something called individual placement and support in some parts of the world, IPS, I don't know in France. The idea is that you find a job for someone, they go into that job and you try and support them to keep that job. A real job paying a real wage. Generally, it tends to have better long-term rates of employment compared to traditional sheltered work. But there's also evidence now on the cost effectiveness of these programs. This was a study called, what was it called? I've forgotten now. Equalise. It was called the Equalise study, and it was done across 6 European countries, not France, although Quebec was actually involved, as I understand it. And the point here, again, looking at this from an economic point of view, there were savings to the health system, savings to the public purse in general, other parts of the government, and savings to society in the first 6 months per person of around about £3,500, so around about €5,000 per person who was enrolled in these individual placement and support projects. Okay, the savings reduced over time, but there were people who maintained employment over the longer time period, and there were benefits both to the employment sector and to society as well. So there are economic arguments to be made around employment. Combining the issue of employment and the need for long-term data, I think this is quite an interesting study. It's from America, and it's been shown quite a lot now, but what it does show is that those people who had a long-term psychotic illness and substance abuse, so it's dual diagnosis, substance abuse and psychotic illness, they compared the use of healthcare services between those who maintained steady work, mainly in employment over a 10-year time period, compared to those who didn't work very much. And what they found was that the use of healthcare services, the costs and the use of healthcare services was significantly lower for those who maintained steady work over a 10-year period. So again, the thing is, from this point of view, not only is it the question of trying to cost the impact in terms of time out of work or time out of education, but also to demonstrate that actually investing in measures to try and help people return to work or having work as part of the recovery process can also have benefits to healthcare systems. The challenge is, though, can you replicate, could you evaluate this in a French context and find the same results? And again, there are economic modelling studies that try and broaden the case for investment by looking at this. This is one study from England, which identified savings from early intervention services to the healthcare system, but they also identified savings in terms of employment, because more people went back to work, because these early intervention programs in England, some of them include vocational rehabilitation experts as part of the teams, and they put some emphasis on getting back into work. And there were also some benefits as well in terms of avoiding violence. I know violence is rare, but there are very small, even though there may be a very small number of people who are violent with a psychotic disorder, the economic cost, if somebody loses their life, even though that's very, very, very rare, that economic cost is so large that doing things to deal with violence also have a significant impact at a societal level. Another gap which I'm not going to say very much about, but I just wanted to highlight it because it is a gap. We know very little about the long-term consequences of dropping out of school, dropping out of university. We don't know very much about the costs of interventions to help people complete their schooling in terms of cost effectiveness. There really are no economic studies in this area that I can see. And yet I can point to, I know in Toronto and maybe in Montreal, but certainly in Toronto, there are specialist psychosis support units that have an education department that help people get through their exams, that help people have a more flexible education structure. But why don't we look at this as well? It's not just about being out of work, it's being out of education and losing the opportunity to develop yourself to actually have a better working life. And yet psychosis affects so many people at a young age in their lives. And I think this really makes a difference. And I wanted to show one slide, just one slide on this, and it's a very simple slide about Australians with schizophrenia and likelihood of being employed, and the association broadly with school age. And what it shows, young people in Australia who have a single episode of psychosis and make a good recovery. But if that single episode occurs during the years of schooling and they don't complete their schooling, which means having 12 years of education apparently in Australia, only 16% of those people were employed, I think it was 4 or 5 years later. But if measures were in place to help people complete their schooling, 2/3 of people were in employment. And all the way down, more or less, with these examples, people who have multiple episodes of psychosis but still make a good recovery, complete their schooling, better long-term outcomes in terms of being in work. Even with a partial recovery, rather than a full recovery, the outcomes are better. So another issue to think about, a gap in what we know economically, but where we have to work with clinicians and actually experts from the education system, is better ways of ensuring that people don't lose out on educational opportunity as a result of psychotic illness. So I've tried to just show a few things really to argue the case strongly for physical health, to argue the case for longer term data collection and to look at that both from a clinical point of view and an economic point of view. To argue as well to put more emphasis on the impacts of time out of work, but it could also be time out of your normal role in life. Not everyone has to work. You may be a new mother or even a new father looking after your child. And that does have you're making an economic contribution to society if you're looking after your children. Or if you're a retired person, people don't stop making a contribution if they don't work. So it's important to also recognise that there are consequences for everyone if their social functioning is reduced. And these have consequences for all of us. Because again, I know psychosis is less common in older people, but at least in England, it's the case that many grandparents end up caring for the grandchildren because childcare is so expensive. And if you're not very well and you can't do that, that actually has a big impact for families. Older people spend money much more than younger people actually in many ways, and that also has an important impact on the economy. If you don't spend money, the economies don't grow. So there are lots of issues to think about, and I've not talked about all of them. I've just highlighted physical health, employment, and the importance of long-term data, and to think as well about education. But there are other areas. If you're interested in some of the other areas, we produced at the LSE a report very recently for a charity in England called Rethink, which is about the economic case for investing in the recovery of people with schizophrenia and psychosis. And there we looked not only at early detection and early intervention, but we looked at some employment-related interventions, but things like support for people who come into contact with the criminal justice system. There's a new system in England now, I don't know if it exists in France, of having specialist mental health support in police stations. So that if people come into a police cell where you're held if you're arrested, you may get a psychiatric assessment there and then and psychiatric support. There's issues around housing interventions, support with welfare. I haven't talked about any of those. They all have economic consequences, and they can all strengthen the case for doing something to support people with psychosis. So it's not just about counting all of the costs. It's also about everyone who works in the mental health field actually standing up and being counted. Not to be ashamed or to feel bad about saying that there are monetary reasons for doing something, because these monetary reasons strengthen the case for action. The economic impacts are really profound of living with schizophrenia or psychosis, but we miss out so many of them. And how on earth we can miss out the impacts on physical health, I just don't understand. There is a real potential for some genuine economic savings, particularly if some of these physical health problems can be avoided. But we need to have good, consistent methodologies in how we both estimate cost, but also do the cost effectiveness studies. And there are opportunities to do this, and having data sets like you've been constructing here in France through the expert centres really can make a difference and play an important role, not just in terms of clinical recovery, but also helping to build alliances with people in the physical health world, with people outside of the health sector, to really try and provide a more powerful argument to governments and to society that schizophrenia is something that we don't just ignore, that we all have a role to play as economists in highlighting the problems, and you as clinicians in doing something about it, in terms of really trying to make a difference to people's lives. So, merci beaucoup. Thank you very much.